Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our webinar on the new CAQH Core report, Altogether Now, Applying the Lessons Learned of FFS to Streamline Adoption of Value-Based Payments. I would like to mention a few logistical items. You will be able to download a copy of today's presentation from the caqh.org website tomorrow. In addition, a copy of the slides and the recording will be emailed to you in the next few days. We will save time at the end of today's program to respond to your questions. In addition to our webinar presenters, who I will introduce in a few minutes, we have several experts on the line to assist with Q&A as well. These include Steve Lazarus and Margaret Amatayakul from BIG, who co-authored the report, and Aparna Higgins from Ananya Health Solutions, who is providing ongoing guidance and review for this effort. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. This webinar is part of our series on the topic of value-based payments. I would like to thank our featured speaker for joining us today, Dr. Susan Turney, CEO of the Marshfield Clinic Health System, and also a member of the CAQH Core Board. Thank you, Dr. Turney, for your continued guidance and support. Today, we will start off with introductions from CAQH Core as well as Marshfield Clinic to help set the context for the report findings. We will then move on to the report itself with a summary of the methodology, followed by the opportunity areas and recommendations contained in the report, and we will conclude with next steps as well as a call to action. So let's get started with our first presenter, CAQH Core Director, Erin Weber.
Thanks, Jessica. I'm very excited to welcome Dr. Turney to our presentation today. She is going to start off and share an overview of Marshfield Clinic Health System's experience with value-based payments, and then she and I will go back and forth talking about how some of the opportunity areas in the report are impacting the industry today. Dr. Turney?
Thank you very much, Jessica. And again, my name is Dr. Susan Turney, and I am the CEO of Marshfield Clinic Health System. And I think it's always great to tell stories because by sharing this, I know it is a way that we can relate to the operational side of the value-based payment and some of the confusion that people have around what this means to them in their own organizations. And I really am excited about the CAQH Core's report, Altogether Now, Applying the Lessons of Fee-for-Service to Streamline Adoption of Value-Based Payments. I had one colleague who said this is a very pivotal report in the industry and important for everybody to read. And it is a precise and thorough report. It does clearly communicate the dilemmas that we're talking about as a health system, and I'm sure many of these conversations are occurring around the country with each of you every day. To give you a little bit of a deeper background as to the history with these kind of issues, I was formerly CEO of MGMA, and I also practiced as a physician for over 20 years at Marshfield Clinic Health System. So during that time, as you can imagine, there have been a lot of changes with payment models and certainly payment reform. And just to name a few, as you think about the journey over the last 20 years, Marshfield Clinic was actually part of the physician payment reform era when we participated in the Medicare Volume Performance Standard Demonstration back in the 90s. We then participated in the Physician Group Practice Demonstration Project. Some of the information that came from these processes are value-based reforms that did actually lead to the Accountable Care Organization, which we then participated in for over 6 years in a Track 1 ACO. We have also had attempts with CMS to participate in bundling initiatives, multiple alternative payment models, and most recently, the proposal for our Contessa-based hospital at home proposal was unanimously approved at the Physician Technical Advisory Committee on alternate payment models. So I think the key here is that there is a lot of activity. There's no one size fits all. And there certainly is no one health system that can solve the issues that we face. as we transition to value-based care. We do need to work with others, and we need to make the transition to whatever is going to work, both feasible and scalable in a much broader context than it's been today. So I think this is, for me, why CAQH Core is so important as an industry-based effort to really address these operational challenges of the value-based payment system. But as I go to the next slide, before I get into some of our unique challenges around value-based payment, I want to give you a quick look at Marshall Clinic Health System in the hopes that this will provide some context for my additional comments. We are an integrated delivery system, and we do have a provider-based health plan. We have nearly 1,200 medical providers and see a little over 3.5 million annual patient encounters in a year. And if you look at the state of Wisconsin in the left upper corner of that map, we serve the entire state, but our primary service area is everything north of the number 1916. Next slide. The key for us is that we are one of the nation's largest rural health systems, and that is something that we can really take great pride in. And in fact, they bale hay right out my office, which is always very fascinating. Our philosophy is that we care for people regardless of their ability to pay. So when you think about the demographics that live in our communities, we tend to serve a patient population that is older, sicker, and poorer than many other places in the country. So it's key for us to really be a fully integrated system with both the clinical care delivery arm and working with one of our primary payers, our own provider-based health plan, but our commercial Medicare and Medicaid enrollees, which is a huge part of our overall population. And I can tell you that for us as a health system, we have a real sense of urgency around value-based care. We know that our patients need a system that can lower costs. We know that we need to better manage chronic disease, and it's critical that we care for patients at the most appropriate and most convenient site for them, which oftentimes means local. Next slide. So now that you know just a little bit about my background, let's proceed to the main topic of today, which is value-based payments. Certainly, all of you know that value-based care is a delivery model in which providers are paid based on their patient health outcomes. And value-based care continues to really come to the forefront of these discussions, as many believe that this model really has the power to improve and change the trajectory of our national health expenditures. We need to impact both morbidity of disease as well as mortality. So that success in this care is often measured in terms of the triple aim, and I think everyone knows achieving better care for individuals, better health for our populations, and doing all of this at a lower cost, but also having a healthy workforce. Value-based payments, or VBP, on the other hand, cannot be used to describe the describe the strategies that are used by purchasers to promote quality and to promote value of healthcare services. And the opportunity really is to include incentive payments, not just penalties. So the industry is really doing more than talking about these models, and it's estimated that 30 to 50% of providers are currently engaged in some value-based payment, and that by 2020, over half of all healthcare spend will be tied to value. Right now, as an organization, we do have about 45% of our revenue at risk. So we are deeply embedded into both value-based care and value-based payment. So what we can see from the models that already exist today is that there have been great cost savings, and we have been able to either maintain or improve the quality of care. So I'm very proud of what we've done as an organization, and you've heard a little bit about me and about our health system, but we have a lot more work to do. So right now, I'm going to turn it over to Erin, who is the webinar director for CAQH, and she will talk a little bit more about the report.
Thanks, Sue. Again, we really appreciate you joining us today Before diving into the report, I'd like to give a little context and background as to who we are at CAQH Core. CAQH Core was founded in 2005 to bring industry stakeholders together and simplify the exchange of administrative data. Back in the late 90s, when the HIPAA legislation was originally passed, the intention of these transactions for eligibility, claim status, et cetera, was that they could all be done automatically between providers and health plans. Around 2005, the industry was still challenged to fully automate these data exchanges. And so CORE was founded to create a level of business rules that sit on top of the HIPAA standards to help improve and accelerate the adoption of the standards. Our mission is really to drive the creation and adoption of the rules and align administrative and clinical activities among all stakeholders. Operating rules make electronic data transactions more predictable and consistent regardless of the technology. And we see our role not just as a developer of operating rules, but really we have a full integrated model to work with the industry, which includes certification on the operating rules, providing technical assistance, promoting adoptions, ensuring ROI. This really is an integrated model where we are focused on aiding the industry in moving forward. Today, CAQH Core has over 130 participating organizations who are coming together to work in collaboration to develop and maintain operating rules to achieve this goal. Our current operating rules are divided into 4 phases. Of these 4 phases, 3 are federally mandated through the Affordable Care Act. And according to my tally this morning, CAQH Core has awarded actually 337 certifications to organizations that have demonstrated conformance with the operating rules. Moving to slide 12, Core's experience in bringing healthcare stakeholders together to develop and agree upon and adopt business rules that improve the exchange of electronic transactions is really translatable to VBP. Our operating rules have led to significant operational improvements, reducing costs and improving care delivery and administrative coordination. Based on this experience to date, the CORE board saw an opportunity to expand CORE's focus to include supporting the development of a sound operational system for VBP. Our board members observed that they were experiencing many of the same challenges CORE was initially founded to address: variation in the operational and administrative functions of healthcare. Early adopters of VBP were using proprietary approaches and inconsistently adapting existing systems to support these new payment models. The board felt it critical the industry address these costly variations before they became entrenched. Our goal is to energize an effort ensuring the historic volume to value shift continues to be unimpeded by administrative hassles through collaboration and applications of lessons learned in the fee-for-service space. With that bit of context, let's take a deep dive into the report itself, beginning with the origin and methodology. The report analyzes operational challenges that may slow or add cost to the implementation of value-based payment. We know that creating or participating in a value-based model requires an intensive amount of time and resources for all stakeholders involved. In our research, we looked to identify the biggest operational barriers to success and found that the lack of consistent expectations created inefficient business transactions. The report details 5 potential opportunity areas for action, which, if addressed, would minimize industry variation and, if improved, would smooth VBP implementation. We further identified 9 recommendations and strategies to address these challenges, which could be led by CORE or others. If you take one message away after reading this report, I think it's important that it be that none of these potential areas for action would be successful without industry collaboration. So CORE identifies over a dozen candidate organizations in the report consisting of industry organizations and thought leaders to successfully propel value-based operations forward. No one organization, as Sue said, is going to solve these challenges. Without industry collaboration, these models will continue to be plagued with opaque payment structures, ambiguous targets, and decentralized data structures. So very briefly, I'd like to mention how the report was created. CORE began by analyzing industry barriers to value-based payments adoption and various industry efforts to address these challenges. Several initiatives such as HL7's Da Vinci Project and CMS's HCP LAN, and even recent legislation such as the 21st Century Cures and MACRA have pushed these issues to the forefront even since we began this research. Through this work, we began to shape our potential opportunity areas. After the initial research, we then conducted about 20 structured interviews with multi-stakeholder entities to confirm, refute, or add to these potential opportunity areas. The organizations that participated represented a wide range of experience implementing these models, from those participating in only government-required quality payment programs to those with populations under fully capitated payments. We were also able to take advantage of our diverse group of core participating organizations through a comprehensive survey on the topic as well. So now let's take a look at our key report findings. We'll discuss the potential opportunity areas for action, and Dr. Turney will be sharing some of Marshfield Clinic Health System's own experience within these areas. Dr. Turney and I will be taking your questions at the end of the presentation, so as a reminder, you can type your questions into the questions panel on your screen as they come to you, and then we'll categorize them and catalog them for the end of the session. So on slide 17, when conducting our research, it became clear that variation in operational processes was impeding success under value-based payments. If the industry is going to be successful in lowering healthcare expenditures while improving quality and bettering the health of patients, there needs to be a common foundation that supports evolving models. This foundation should reduce administrative burden, improve the exchange of information, and enhance transparency among stakeholders. Our research identified 5 potential opportunity areas for action: data quality and standardization, interoperability, patient risk stratification, provider attribution, and quality measurement. Addressing these opportunities would result in a more uniform approach which would streamline VBP operations for both health plans and providers without compromising the competitive value of VBP models or the care of the patient. So what do these opportunities actually mean, and why are they important? On slide 18, you'll see the first of our opportunity areas, data quality and standardization. Health plans and healthcare providers agree that there is a challenge of too much data in VBP. When caring for populations, it's important to be able to access the correct data at the correct time in the point of care and extract actionable insights. But sifting through the data noise can cause undue burden on both providers and payers. This was heard throughout the research. Additionally, non-standardized data and data quality also pose challenges to VBP operations, so improving the accuracy, completeness, and timeliness of data and enabling easier access to high-quality data must be priorities. An example of data standardization issues that permeated through our primary and secondary research include missing or inaccurate provider identification. Despite a mandate requiring the use of the National Provider Identifier on claims, both commercial and government plans often use other identifiers in addition to or in place of the MPI, including the TIN and their own proprietary identifiers. Additionally, being able to identify the provider's specialty on a claim is especially important with VBP. Another example of non-standardized data is inconsistent use of terminology. The term admissions is a great example here. Do admissions include only inpatient stays, a trip to the emergency room? Without consistent identifiers and common terms, it can be difficult to measure the timeliness and the nature of care, which can lead to issues with reimbursement, quality measurement, and cost. To combat these challenges, CORE recommends 2 courses of action. First, promote and enforce data set and data element standards, especially when they're federally mandated. The identification and role of the provider in value-based models must be clear to accurately disperse shared savings or shared risk. Enforcement of data element standards such as the MPI could improve this transparency. The second recommendation is to pursue a voluntary agreement on the uniform definitions and terms commonly used in value-based models. An example could be adopting inpatient bed stay as the one and only definition of an admissions event. Clarity around definitions, terms, and code sets will improve care delivery and care management capabilities, promote transparency, and strengthen the ability to perform quality and cost analyses. So Dr. Turney, would you like to tell us a little bit more about your experience with data quality?
You know, certainly, Erin, and thank you for the discussion around the report. I am really right in the thick of all things and many of these changes that are happening because we as an organization are aggressively and are progressively pushing to transfer from predominantly fee-for-service to a fully integrated, fully capitated system. You know, in our past, we weathered a tremendous amount of criticism from CMS, which said we were upcoding when we reported a very high incidence of diabetes in our patient population, which CMS didn't really see because of their protocols limiting the number of diagnoses on a claim form. So the Congressional Budget Office subsequently recognized the epidemic of diabetes as a contributing factor to both the comorbidities as well as mortality of this population. And this really was a significant problem for us, and also in assessing any type of risk stratification when you look at the entire population of patients that we serve. When we were living through this problem, we really didn't have a name for it, but now we recognize the problem as arising from truncation of the data. This is just one example, however. Another challenge is trying to align what CMS is doing with our own ACO measures, along with the Wisconsin Collaborative for Healthcare Quality, and then balancing what our health plan needs are with its healthcare effectiveness data and information set, or HEDIS measures. So the data that we provide to WCHQ is different from that which we need to submit to many other systems. And a part of the reason for this is that we have our own quality assurance program. So yet another issue is that some organizations aren't required to send in certain measures. So if we could really standardize on quality measures, then we wouldn't have all these different flavors of the same quality measure. That really creates a tremendous amount of confusion, certainly inefficiencies for everyone involved, the payers and the providers, if we're really trying to get to that truly value-based environment. There isn't anyone in healthcare that isn't focused on quality measure and measuring results. In fact, everyone in healthcare is focused on quality and measuring, but many times we are focused on very different measures. For example, one of our payers, Anthem, may be focused on certain measures, and our health plan, Security Health Plan, may be focused on completely different measures, or may even look at different ways of measuring. This puts a lot of responsibility and frankly a lot of cost on the provider to try to figure out what we need to do with each patient and how to report that data. So our focus is on reporting the data and not looking at the measure and trying to figure out how to provide the best care. We also know that we need to do more to codify social determinants of health and how to really account for the impact that the social determinants have on a person's health. So we're going to flip to the next issue, and that's around interoperability. So I'm going to let us have Erin talk us through that next opportunity area.
Thanks, Dr. Turney. I'm glad you brought up the importance of social determinants of health. We've seen so much research lately about how these factors need to be considered in a patient's care plan to effectively improve outcomes. But these patient-reported data fields can be even more difficult to report consistently and accurately. We'll need a strong foundation for existing data fields before we can expect an HIE to accurately supply social determinants of health information on a patient. So moving to slide 21, we turn to our second opportunity area, interoperability. Interoperability has been a challenge in the healthcare industry pretty much since the dawn of time, and we've all heard and experienced the frustrations. Data retrieval and integration roadblocks cause delays in analytics and prevent real-time actionable data from reaching the point of care. Not only are improvements in technology necessary, but process interoperability also needs to be addressed. Process interoperability is the ability to pass information from one system to another while maintaining the accuracy and consistency of data, workflows, connectivity processes, and data timeliness. Stakeholders engaging in VBP are especially hindered by the lack of interoperability. The models require new and complex process capabilities to deliver patient information across the care continuum. This data needs to be accessible to all parties involved. Improved communications with patients is also necessary to support patient engagement and shared decision-making from both the providers and plans. These process changes may also require new agreements, partners, workflow, and data collection. So on slide 22, you'll see our two recommendations. First, to promote technical interoperability by encouraging the use of existing standards. And second, to promote process interoperability by cataloging value-based best practices to streamline and standardize both internal and external workflows. A fully interoperable EHR system should be capable of sharing longitudinal patient-level data about individuals and should support the development of better outcomes-based payment structure. New standards are being identified every day to address these needs, and expectations for marketplace adoption should follow pilot testing. With more fluid data interactions, we could have actionable and trustworthy analytics for care management, quality measurement, patient attribution, and more. Requirements in the Cures Act are intended to help streamline data sharing across the continuum of care. As we move across the opportunity areas and recommendations, you'll notice how there's not a one-size-fits-all solution. Every value-based model is different, and every organization has different needs and requirements. But by collaborating where synergies can be found, the industry can move the needle towards a more efficient system that spends less time on transactions and more time with the patient. So let's hear a bit more from Dr. Turney about her experience.
You know, I think Erin outlined it very well, and a major challenge here really is with the value sets. We are in a position where we're being told to use these value sets, but the value sets aren't defined, or in fact, oftentimes are even quite vague. And that really is a fundamental issue. We struggle to communicate with other healthcare organizations when the value sets are not defined. So that another issue I think can be illustrated with this example. Let's say one of our patients decides to get their flu vaccine at Walgreens. So unless Walgreens puts that information into our state database, we won't know about it. So then we have incomplete data about our own patients. We might have more access to data if a patient is covered by another company like Blue Cross Blue Shield, for example, who we have a value contract with, but still not as much as if that patient were a member of our own health plan, security health plan. So we create a situation where we have an incomplete picture of our own patients because we don't always collect the same data and we don't always share it well across organizations nor across the entire continuum of care. So although this is a relatively simple example, without this complete data picture of a patient, it's really hard for us to know if we are truly being cost effective or even to know how much a certain disease process costs us as a system. So I'm going to hand it off again to Erin, who is now going to talk about patient risk stratification.
Thanks. If there's time during our Q&A session, I would love to hear a little bit more about how you think having your own health plan but still contracting with other payers may help or hinder this interoperability. So now we're going to take a look at patient risk stratification. Models for patient risk stratification and patient risk determination vary considerably across the industry. Our research identified two major operational challenges. First, a lack of transparency. Providers are often unclear as to how health plans are using risk assessments and whether risk adjustment tools are being applied for patient risk stratification. This lack of clarity may impact the health plan provider relationship, which is critical to successful value-based outcomes. Second, a lack of uniformity. Even when health plans are using a patient risk stratification methodology, each contract between a health plan and provider may use a different or modified methodology, leaving providers with different pictures of their population. Reducing this administrative burden would allow providers to focus their resources on the appropriate patient populations and reduce their potential financial risk. Moving to slide 25, the total number of risk stratification models is unknown. There are approximately 7 publicly available models today which are most commonly used. These models are based in some degree on comorbidity, however, specificity is not readily available. Factors such as social determinants of health in a patient population are becoming more important, but it's unknown which models place emphasis on these factors outside of a provider's control. Additionally, there's been no cost analysis or demonstration of the effectiveness of each model to guide the industry in best use. CAQH Core recommends more industry education on the role of risk stratification for value-based payments and its challenges. While it may not be possible for the industry to coalesce around a standard methodology, a more transparent and unified approach would enable better care coordination. Dr. Turney, what's been your experience?
Certainly. You know, if it were easy, we probably would have done it already. But a huge, huge component of value-based care is really risk stratification. And you've already said it. It's an area where change is dramatically and drastically needed. You know, even when we're working with our own health plan, it's very hard to stratify patient risk. Some of the available risk models that exist today are indeed proprietary, and it makes it very hard for us to really fully understand what goes into that model. And because we have that gap, it's really hard for us to build an effective intervention for our patient populations. If you step back and look at the CMS model, that is even a more complex model, and they have in the past changed their methodology midstream. So as with most models, given they developed that they were developed using claims history, there's a significant reporting delay in the process, and it just makes it very difficult for us to really effectively react. We know that there is no model out there that's perfect, but we really can't let the perfect be the enemy of the good. I think this goes back to something you said earlier, which is really, let's get a common definition for the model, and let's have components of the risk stratification that we all can utilize. So that in a clinical setting, when we're taking care of patients, you know, we're obviously very concerned about those that are high risk. That's most often where the intervention is critically needed. So when you think about how health plans are beginning to realize that we are focused on these high-risk patients, they are also focused on patients whose risk is rising. So together, if the health plan wants to identify a patient who may cost $10,000 a year to care for, but instead is heading in the direction of someone who's going to cost 5, 10, 20 times more than that a year, we want to be able to communicate that to the provider. So the health plan can do that. They need to communicate to the provider. They need to say, hey, this patient isn't in that high risk category yet, but they well could be very soon. We know this based on the information that we have today. So let's act. Let's head this off. Let's get there before they become high risk and they are very costly to care for. Plus, it's about the patient. We want the patient to feel well, and the earlier the intervention, likely the better the outcome. So we really see that patient risk stratification is an exciting opportunity when you think about it, especially when you look at the advances that have occurred in machine learning, getting the information to the point of service. And I think that this is an opportunity, and a huge opportunity, for us to use this technology to more accurately, more cohesively stratify the risk, then report it to the provider so that they can truly intervene with the most appropriate care. So Erin, I'm going to hand it back to you to talk a little bit more about one of the action items, which is provider attribution.
Thanks, Dr. Turney. The availability of new technology definitely provides opportunities to reduce administrative burdens, whether it's stratifying patient populations or making outcome predictions based on patient records. So now let's turn our attention to slide 27. In value-based payment models, attribution refers to the process where providers are assigned a group of patients for which they are accountable. Attribution methodologies can often be opaque, and since each provider works with several health plans, patients can be attributed in a multitude of different ways, prospectively, retrospectively, based on geography or patient history. The logic behind the attributions may not be known, making it difficult for any single treating provider to identify to whom a given patient is attributed. Or a patient may not even see the provider to whom they've been attributed. For example, many diabetics see an endocrinologist as their primary care provider. Without a full understanding of how methodology is used and applied to their patients, providers can make erroneous assumptions, which could lead to ineffective decisions about patient needs and an inefficient distribution of resources. The variation and opacity of these provider attribution models can be a large impediment to success under VBP. We will need to improve provider awareness of patient attribution through clearly defined and accurate provider data, as well as streamline and improve the transparency of these models. By improving this transparency, both providers and patients are empowered in decision-making, and cost and quality can be properly assessed. I'll turn it back to you, Dr. Turney, for your thoughts.
You know, clearly, as we think about managing individual patients as well as our population of patients, attribution is really key, and it's an issue that needs to be discussed and resolved. The important thing really is to align the attribution with the plans that you are contracting with, because you need to know who you're accountable for. You also do get some pushback from providers when you show them the list of patients they're attributed, and it's obvious the reasons why, because there are circumstances where they're going to say, that's not my patient, or the patient's not being managed by me. And, you know, we want to do the right thing for our patients, so we need that information on a real-time, ongoing basis. You also have patients who don't use care appropriately, and they do move around. They do see different providers. Their care is not well coordinated. Or you get a patient who just comes into the walk-in clinic once in a while, and that patient may get attributed to a primary care provider that really isn't their patient because they aren't interacting consistently and regularly with that patient. So it's going to be essential to develop processes to address these patients' needs and to assure that they are properly attributed. If you're going to manage the patient, you want to know who those patients are. That way, the patient will truly get the best care. And another issue really is that anyone who can transmit the health data, like a medical assistant or a health information clerk, right now can get a national provider identifier. And when we go back to clear definitions and trying to make sure that we can assign responsibility, it really would be helpful if we have that clear definition of what a provider is. So I'm going to hand it back to you, Erin, to talk about quality measurement.
Great. You brought up earlier the rising use of retail clinics like Walgreens, and we have this new class of patients who will see their primary care physician once a year for a physical, but will visit a retail clinic for any needs in between, which really gives that primary care physician an incomplete picture of the patient's health. I mean, I personally can't even count the number of times I've taken my kids to urgent care rather than to the pediatrician just out of convenience. So now we're really starting to see how all of these opportunity areas are connected. Without a clear picture of who's providing care to a patient, it's difficult to access the data necessary to coordinate care, even when the systems are interoperable, which means you can't accurately categorize a patient's risk levels. And then the data is not standardized, so information is constantly being converted from one form to another to try and paint a population-wide picture. This brings us to our final opportunity area, quality measurement. This is an example of an opportunity area where CORE might not be the organization to tackle the issue. There are many other organizations and efforts such as CAQH and QF that are doing a great work in this space. But as we did the research, this topic came up so consistently that we could not exclude it from the report. Though quality measures are clinical, gathering data and producing reports is an operational burden. Providers reported 3 overarching challenges across quality measure programs. The first of this issue is too many measures. For example, in the more than 30 CMS programs that use quality measures, there are 850 unique measures, and only about a third of these measures are used in more than 2 programs. This leads to our next challenge, too much reporting. Physicians are spending over 15 hours per week on average entering information for the sole purpose of quality measure reporting. Even though providers are spending so much time on quality measurement, most report that these measures provide little to no insight and fail to identify next steps for providers and patients. So in order to address these challenges, CAQH Core recommends supporting existing industry efforts by providing education to promote the need to improve consistency in quality measures across programs, reduce quality measure data collection burden, and require quality measures to be actionable. Over 30 state and regional efforts are currently focused on the improvement of quality measurement, and many of these efforts have identified the need for more outcomes-oriented measures rather than process measures. Effective patient-reported outcome measures can capture patient health status while keeping the provider collection burden at a minimum, ultimately empowering patient decision-making. Dr. Turney, your thoughts here?
Thanks, Erin. You know, we have a very robust quality monitoring system within our organization, and our focus really has been on helping providers focus in on the key quality measures. We also have clinical quality coordinators as part of our care teams to really bring patients in for things that are needed for wellness measures, and that really does alleviate some of the burden on the provider. And as proud of as I am of what we're doing, as much as we do to try to do all of this on the front end, we are still confronted with all of the issues of non-uniformity that you mentioned. And then once you get outside your own system, there are multiple health systems using different quality measures for diabetes, for example. So that if we, again, had some consistency in the measures, it would significantly help us as an industry focus on, I believe what we're here for is improving quality for the patient. So what happens when you have all of these different systems using different quality measures, instead of focus on improving the quality, you spend a tremendous amount of time trying to figure out why the various flavors of one quality measurement are slightly different. So I can't stress enough the importance of what we've just discussed. And I do want to really take a moment to summarize some of our experiences with these opportunity areas and with the CAQH Core VBP report. Erin, I'll have you go to the next slide, please. We are really very optimistic that there are many organizations across the industry that want to do what's best for the patient and truly want to understand the need for uniformity and standardization around some of these key issues and frustrations that we have every day. Any progress in this field is really good progress, and we have seen some improvements around standardization, but the system still doesn't work well enough, and we've been talking about it for years. So it's really time to take action. And that is really why the work of CAQH Core is so important. We truly have an opportunity to make value-based care work and to avoid many of the pain points that we have seen in the fee-for-service realm. So with that, what I'd like to do is hand this off to Jessica Porras, our Senior Manager of Education and Outreach, for one of our polling questions.
Thank you so much, Erin and Sue. Dr. Turney, I really appreciate you making these opportunity areas and challenges come alive for us. So let's take a quick pause for our first polling question. We would like to hear from you. What's the most significant operational challenge? So let's go ahead and we want to hear from you. Is it data quality, interoperability, patient risk stratification, provider attribution, or quality measurement? And while you are filling this out, if you do have any questions for the Q&A, it's coming up in the next few minutes. So let's go ahead and close the poll and share the results. There's, one that seems to bubble up and a couple of others that seem to be of importance to our audience. Is this, for our panelists, is this what you expected, or?
It doesn't surprise me, largely because data quality and uniformity is a standalone issue, but it's an issue that impacts patient risk stratification, provider attribution, quality measurement as well. Like I said, all of these topics are kind of interdependent on each other. So I'm not surprised to see that as the top opportunity.
Thank you so much. So Erin, I believe you have some next steps and a call to action.
Yeah, so I'd like to share with you all our next steps with our value-based payments initiative. We've put out this report, but that's not the end point. Obviously, there is a lot of work to be done. We will be forming an advisory group which will be charged with narrowing down the list of potential opportunity areas for action to one or more strategies that CORE will pursue. This group will then continue to provide guidance and insight to Tiger teams who will be more responsible for executing on the selected opportunity area recommendations. The outcomes of this work could be many. They could be best practices, they could be pilot efforts. It really is going to be dependent on what the advisory group prioritizes. Before we begin answering your questions, and I hope that you have all been submitting them while you've been listening, I'd like to leave you all just with a couple closing thoughts. Value-based care is here and changing the trajectory of healthcare. Action is needed now to avoid the scenario that emerged in the fee-for-service environment more than 2 decades ago, when the adoption of electronic transactions was slowed due to a lack of common rules for uniform use. CAQH Core believes the key goals of VBP, that triple aim that Dr. Turney mentioned, can be achieved in part through greater industry collaboration for more uniform and streamlined approaches to VBP operations. Addressing these 5 opportunity areas will enable the evolution of value-based payment while minimizing unnecessary and burdensome variation. We encourage all of you on the call today to consider how your organization can play a role and reach out to us if you want to engage further. With that, I'll turn it back to Jessica for questions.
We have one quick polling question before we go to questions, just to keep everybody excited about our Q&A portion. So let's open up that poll real quick. Part of our, the success of this work will require all of your help. So please let us know if you're interested in participating. We'll just leave that open for a few seconds, and then we can go to our exciting Q&A portion. Okay, thank you so much. And thank you to those of you who have already submitted questions, and there's still time to submit. Just type it into the questions panel. So for the first question, Erin had mentioned earlier in the presentation, she had started with a question posed to Dr. Turney. How does having your own health plan but still contracting with other payers help or hinder interoperability at Marshfield? Dr. Turney, I'm really curious to hear your thoughts on that.
Well, perhaps I could start. Our health system is connected to our electronic health record, and at all of our sites across the state, we have the same electronic health record. So from that perspective, it does make it easier to have access to the information about the patient at the point of care. Not all of our patients are covered by Security Health Plan. We have other commercial payers. We also have patients in the Medicare and Medicaid program. But having the claims data as well as the clinical data is really the sweet spot that allows you to gather information around patient care. Certainly, probably giving an example might help. Congestive heart failure, we know, is a very costly disease to manage, and it requires tremendous amount of coordination of care. And the team around a heart failure clinic needs to be quite broad and quite deep. But the first thing you need to do is identify the patient. You need that risk stratification. Which of the patients with congestive heart failure are going to need to be seen in a heart failure clinic and be managed very closely to, one, maintain the best health status they can, but to try to keep them out of the hospital. So we found that through our data, we were able to identify the patients within our health system that were diagnosed with congestive heart failure. And then we were able to take that information and go deeper into the electronic health record information to determine those that had more advanced disease. That once that group of patients was identified, they were able to be considered they were offered the opportunity to be part of the heart failure clinic. Right now, we're managing not quite 6,000 patients in the heart failure clinic. And again, the health plan can help by identifying those that are the more costly patients based on the diagnosis and have had the claims experience that would warrant their participation in better and more coordinated care. So having both the claims and the clinical data is extremely helpful. of those nearly 6,000 patients that are in the heart failure clinic today over a multi-year period, we've been able to demonstrate the mortality rate for those patients has dropped nearly 36%. So we were able to identify the patient, we were able to do the risk stratification, we were able to the clinical care delivery side, get them into the heart failure clinic to allow them to get the best coordinated care, and then monitor the results to see if the program was successful and where we needed to make changes. Once we knew the outcomes, both on the morbidity and the mortality rates of the patients that were being seen through the congestive heart failure. So that's an example of how having the health plan and having the care delivery arm really coordinated care, and I met the triple aim.
Thank you so much. The next question is, do claims attachments have a role in VBP, and what is that role? I'm going to send the question over to Margaret.
Yes, Erin, thank you. It seems to me that claims and therefore claims attachments are not going to go away anytime soon. So I think that transitioning to value-based payment doesn't seem like a likely scenario for purposes of ignoring improvement needs in the claims attachment data and operations. But even in current iterations of full risk value-based payment, there is still a need for exchange of encounter information. We heard this from people in California who are in a heavily capitated situation, the highest risk possible. They require additional information in many cases. As time moves on, I think, and we're already seeing this in some areas, we heard this in one of the Washington State interviews we did. We can see that claims attachments, whether in fee-for-service or value-based, will be moving away from this attachment concept or document concept to provision of access directly to the EHR or to a registry by the health plan, as well as by other treating providers of a patient, as Dr. Tierney suggested, so that we can get the needed information. I think Steve has some thoughts as well on the data aspect of this.
Yes, thank you, Margaret. The interviews also showed that we need to develop new processes to exchange patient data to support real-time provider workflow and decision-making. And those may be very different from what we're used to from the claims transactions today in terms of speed with which these data transfer and the mechanisms that are used. We interviewed one health plan who's actually providing providers access to their data and tools to use it to manage certain types of patients in an area where the health plan has a huge concentration of beneficiaries. So we should be prepared to think about attachments in quotation marks in ways different from the way we've thought about them in the past. And these approaches for sharing data in other ways than with the claim may drive the thinking around the claim to some very different direction of sharing data in the future, which will apply to all aspects.
Mm-hmm.
Thank you, Steve and Margaret, for that answer. The next question is for Dr. Tierney. How does Marshfield identify its high-risk, high-needs patients, and what strategies do you deploy for the various levels of risk? What can you share with us about that?
Yeah, it's a very challenging question because, first of all, you have to set priorities of what you'd like to be able to do in the value-based care and payment world. Certainly, I think a lot of the focus that we've had are on the areas where the cost of care is very high. Congestive heart failure is just one example. So through the electronic health record and through our business intelligence area, we're able to query for the information that we need to determine where we should focus our time and energy. For example, it might be on diabetes. we know that good diabetic management results in less complications. So if you have the data through the electronic health record, and you can go deeper than what might be seen on a claim form where it lists diabetes, but in the electronic health record, you're going to be able to identify whether there's been any associated eye problems, vascular disease, whether they've had foot exams or regular eye care. So a lot of that is coming from the clinical data within the electronic health record. And setting up the business intelligence to really get at that information is not without its challenges, but it's important to be able to ask questions and be able to retrieve the data so that you can identify the patient so that you can make the most appropriate intervention. Some of the data can come from claim form, as we've discussed already, but the robust information in the electronic health record is really what is going to drive a lot of that care. It matters if the patient's a diabetic, but if you can't tell whether or not they've had a foot exam, it's not going to be a great deal of benefit for the person who's, at the point of care with a patient. So you have to be able to drill down to a certain level of detail, and that is going to occur through the clinical information. I think, different health record systems have different capabilities in order to extract patient information, and but everyone's trying to do the same thing: is to identify the patients that need the interventions or are not getting the appropriate interventions, and then prioritizing how best to manage that patient population.
Thank you so much. For our next question, what payment models do you think are going to be adopted first? Aparna, what do you think about that?
So typically what we have seen based on the experience to date is that in transitioning away from fee-for-service and to get providers ready to move into more advanced payment models, the starting point has been, still a fee-for-service base combined with incentives tied to achievement of quality targets, and then to promote things like care coordination, having a care management fee as well associated with it. And those kinds of payments are what help transition providers away from fee-for-service and get them more ready to move into more advanced payment models. And what we're observing is that once providers have an opportunity to get accustomed to that kind of an alternative approach to payment, then they're ready to move into models that involve shared savings, which is sometimes called upside risk, and then from there on to move into shared savings, shared risk models where there's both upside and downside, all the way to what's called as global budget or global capitation. So there seems to be a pathway that has emerged in terms of moving providers away from fee-for-service all the way to a global budget or global capitation. And typically the entry point for many seems to be in terms of fee-for-service plus P4P plus, care management fee, kind of a model for payment.
Thank you so much, Aparna. And with that, we've run out of time for today. On the next slide, you'll see our VBP series. The ones on the top part of the slide are the ones that you can click on there and listen to our recording. And if you have trouble doing that, you can also go to our website and have access to them. And we have a webinar on May 3rd, where we will have Kate Goodrich from the CMS Center for Clinical Standards and Quality talk to us about what they're doing on interoperability and value-based payments. So thank you so much for joining us. If you have any questions or you're interested in any of our work, this is how you contact us. Have a great afternoon.